My name is Chris Beach. I'm the Senior Vice President of the Minneapolis Foundation, and excited to kick off one of our new learning collaborative series. It's not one of, I suppose it is our new learning collaborative series. Um, as a foundation, we have really started to think about a few of our main values. One of them is that we value proximity. That is, that we hope and we understand that the closer we can get to challenges that are facing our community, those in it and around it, the more that we understand that we can be part of it and we can help find a solution. So this year, one of the things we were thinking is, what if we started gathering our fund holders together to explore some of the local organizations that we have and start addressing some of our biggest challenges that our community has? So what we did is some deep listening. We've listened to fund holders, we've explored and examined where our fund holders are giving to, what types of topics, what types of issues that are important to them. We've listened and we continue to listen deeply into the community because we are giving some of our own resources away in the community. And so we start to understand what is it that our community is saying they need. And now we're trying to tie the two together a little bit here and bring resources so that everybody can have a more full understanding of what's going on and how one might be able to make a difference. Our hope is that through today, you will be inspired, you'll hear some new stories, you'll learn some ideas around this particular topic, but that you'll also come back with us as we have more of these throughout the year. We have 2 or 3 already in the line coming down. I know Amy will explain those as we get closer to the end of this presentation, but we're really excited to be here. Thank you again for participating. We were not sure how many people would come, and without much effort, we had over 70 people RSVP. So it shows, one, the importantness, how important this conversation is around mental health, but also proves to us that this is the right type of series for us to have for our fund holders. We're excited you're all here. What a great one to kick it off with. Thank you to our presenters. And with that, I'll pass it over to Amy.
Thank you, Chris. And again, just to introduce myself, my name is Amy Farr-Walker, and I sit on the philanthropic services team at the Minneapolis Foundation. I joined the foundation about 7 months ago, and prior to that, I spent 12 years working with a nonprofit mental health agency in the Twin Cities. And so I share your passion. I share the connection that I see in the chat there about why mental health is important. And so really grateful to be kind of facilitating this discussion today, this really important discussion that many of you expressed interest in. This is who you came to hear from. 3 amazing organizations that are doing really important work in our community. And so grateful today to have Sue Abderholden with NAMI, Craig Warren with Washburn Center for Children, and Joe Clubb with Allina. And you'll note in the pre-event kind of materials and such, Joe is pinch hitting for his colleague who had a family emergency today. So we welcome Joe rather than Mary Beth, who you may have seen listed in some of that pre-event communication. So I know I could try to list their long bios and their amazing vitas, but instead I've asked them to introduce themselves. We will share our screen here, and each of them gave a couple different slides to share not only themselves, their organizations, but also why they think mental health is important, right? Connecting back to the chat and the reasons that you have listed as well. So we'll ask Joe to start with Allina, and then we'll go to Craig and then Sue. So thank you.
Sure. So thank you. I really appreciate this opportunity. And just at Allina Health, this is an organization that has made a significant commitment to mental health and addiction. In fact, I had worked for a previous healthcare organization, and then got to know Dr. Penny Wheeler, who was then the president and CEO, and really publicly made statements about our commitment to mental health and addiction. And it was at that time that I was interviewing at Allina and invited in, and when she made those statements out loud and communicated that to 28,000 employees across the organization that we will do better, I signed on and really wanted to be a part of Allina Health and this journey. And so as an organization, we really advance our approach as whole person care. And we know that healthcare and mental health care can be very segmented and disparate in our approach. And We're not there yet, but we work really hard to advance care for the whole person. And you'll see the characteristics that we focused in on. And we at Allina Health recognize that we can't do our care alone and meet all needs. So it is really, we are dependent on the community and community partners, and interested enough to be here today with Washburn, who is one of those very important partners to us. We have 17 different partnerships with just across mental health and addiction, in order to serve individuals in that whole person approach. Can we go to the next slide? And so just to give you a very brief overview, we are a large system, 11 hospitals and 90 clinics. I will mention that we have mental health and addiction in 7 out of those 11 hospitals. I'm proud that we serve the lifespan at Allina, so children, adolescents, adults, and our seniors. We have an integrated mental health and addiction service within 50 of our primary care clinics, as well as specialty mental health clinics across the organization. We have grown significantly our partial hospital day treatment and intermediate levels of care. Allina is one of the largest healthcare providers across the state of Minnesota. If we could go to the next slide. This gets more into detail of who we are. So across the left is our continuum. An individual can enter into any of those different levels of care that I have mentioned. But just to give you a very quick overview, we have 250 inpatient beds across those 7 sites. We recognize that mental health does not just happen within an inpatient mental health unit, but across all areas of Allina. So we have psychiatrists that provide consultation in medical units, ICUs. We do have psychologists that are deployed across the organization, again, recognizing the need for short-term intervention. We do have a residential addiction program down in southern Minnesota for addiction. We have advanced our care and approach to individuals who enter our emergency departments. Historically, we have had master's prepared clinicians who actually provide assessments and determine an admission or a discharge. We've actually advanced a brief treatment model within our emergency departments and have brought psychiatry into those areas to provide that treatment, which has really allowed us to think more broadly about where can an individual receive care. It's not always in an inpatient bed, but that leads me to the outpatient programs. We have grown significantly our partial hospital day treatment program and our outpatient addiction. So we think about 250 inpatient beds, and we have grown to 500 chairs for our partial day treatment programs. Those programs serve children, adolescents, and adults. And then our 144 chairs for outpatient addiction services. So just to give you a picture, at United Hospital, we have 100 patients come in every day to receive partial hospital and day treatment services, just to give you a sense of daily service to individuals. And then below is really all of our clinic-based services that we continue to grow. We'll maintain our inpatient beds with some small growth opportunities. Proud to announce that in Hastings, we're going to be opening up a 15-bed adult unit that will start seeing patients within the next few weeks to kind of manage some of the East Metro demand. But our outpatient programs and services, we're on a continued steep growth into these services. I will just offer to you that why I got into this work. I'm a social worker, a clinical social worker by education and background. I was invited in to lead mental health and addiction at St. Joseph's Hospital in St. Paul, and have led mental health and addiction for the last 18 years. But really, when I reflect on this, and we started to talk about this, and it's in the chat, as many people have identified, so many people that we live with and love live with mental illness and addiction. And I reflect back on my mother back in the 1960s as a child. I would come home from school, and if my mom was in bed, it was a bad day. If she was up, it was a good day. We didn't have the words and language to understand that she was, along with chronic health, dealing with depression. and we didn't have language around that. And then I think about a cousin of mine who, because in a small town in Minnesota, everybody took care of him, but he was just a happy-go-lucky guy, and he drank alcohol, and was told by his primary care provider if he didn't stop drinking by the time he was 50, he would not live. And we were all at his funeral at age 50 and would just, we couldn't believe this happened to Tom. We were all so surprised. And so I don't want that for people. I want it to be better for people. And so that's why I do this work. And that's why it's important to me. Thanks.
Thank you, Joe. We'll move on to Craig from Washburn Center.
Thanks, Amy. Good morning, everyone. I'm Craig Warren. My pronouns are he, him, his, and I have the honor of serving as the CEO of the Washburn Center for Children. And I do just want to take a moment before I talk a little bit about Washburn to say thank you for your support of mental health. There still is a stigma around mental health, and the fact that there's 50 plus people who came together today to learn more about what's going on, what the challenges our community is facing around mental health is very heartening, because there still is a lot of stigma out there that prevents people from kind of getting the support that they need. So I'm grateful for your presence today, and I'm grateful for the support that you have provided around mental health. For Washburn, we're really focused on nurturing every child and family's well-being through delivering transformative mental health care. So we are a community-based mental health organization that's solely focused on children and adolescents and their families. And we do that in a variety of spaces. We are embedded in 40 schools in Minneapolis, in Bloomington, and in Eden Prairie. We have 3 locations in Minneapolis, in Edina, and Eden Prairie. And we also meet kind of our clients and their families wherever they're at, out in community, wherever they're at. So our services are delivered really meeting people where they're at. And we have a full sort of continuum of outpatient care, ranging from someone who may receive support on a monthly basis to situations where someone may be in a classroom environment several days a week and be receiving individual therapy and individual therapy and group therapy multiple times a week. So we sort of have a full continuum of care there. And Joe alluded to this, but we're also excited about the partnership that we have with Allina, which we've also expanded to some other healthcare systems, where when kids are being discharged, we're actually able to connect them with a therapist for some intensive therapy right upon discharge that sort of prevents them maybe from being readmitted, which is sort of an innovative model that we started with Allina, and we've continued really with Joe's support that we're very excited about. And I'll pass it over to Sue.
Thank you. Hi, everyone. I'm Sue Aberholden, Executive Director here at NAMI Minnesota. And we really look at providing justice, dignity, and respect for all people impacted by mental illnesses. And we do the lifespan. Most of us here have lived experience. So nearly 100% of our staff, board, and volunteers either live with a mental illness or have family members. I have family members, which is what drives my passion for this work. I've been at NAMI for just a little over 21 years, so a significant part of my life, and really feel the importance of our work. So unlike Craig and Joe, we don't do direct services. So we're not mental health professionals. We don't deliver treatment or anything like that. What we do is peer education and support. So we have a lot of different classes that we offer to family members so that they can understand what their loved one is going through, and then actually what to do. Most of us never learned in our health class how to deal with someone who might be hearing voices or having delusional thoughts, and we really help families through that. We also know that a lot of people have no idea how to access mental health care, what an inpatient psych unit looks like, how do you do the commitment process. So we actually developed over 12 booklets, very simple, kind of explaining the system so that people can look at them, read them, and again, try to guide themselves or their loved ones through the mental health system. We offer most of the evidence-based suicide prevention classes. As we know, suicide has been going up both in Minnesota and across the country, and we think it's really important that we all learn the steps to prevent suicide. We have peer-led support groups, and we have a number of them, both for people who live with a mental illness and also family members, but also for certain populations like LGBTQ+, BIPOC support groups, ones for people from Spanish-speaking communities, ones for young adults because their issues are often different than someone who's in their 50s. So making sure, again, that people have safe spaces and they can share and gain hope from each other. We have a helpline that takes close to 4,000 calls a year on every topic that you can possibly think of, including my loved ones in jail, my child's boarding in the emergency room, I'm calling from Anoka, I don't know why they committed me here, my daughter needs housing, you know, just a number of different things. We also do public awareness presentations. So we're really trying to change the public attitudes towards mental illnesses. People are often afraid of sharing that they are struggling with symptoms because they're afraid of discrimination. That if they share it with their coworker or boss, that they will be discriminated against, you know, sometime in the future. So we're really trying to kind of break down those barriers because we know that early intervention actually yields the best outcomes. We've been doing a lot of work with employers, especially during COVID, because they're more concerned than ever about their employees' mental health. So we do mental health in the workplace. We do a number of health and wellness activities as well. And we also focus on mental illness in the workplace and what accommodations can be because work is so important to people's recovery. We do some work around health and wellness again. Positive psychology. We actually have a class for mental health professionals on smoking cessation to help people with mental illness quit smoking because they have the highest smoking rate. And we also do a ton of legislative advocacy. So we like to say that our mental health system isn't broken. The reality is it was never built. NAMI started over 40 years ago and there was nothing. There were no community services and there were just the institutions who, and frankly, they deserve to be closed. There was a reason they had to close. And so all these years we've been really working at developing new programs, making sure there's funding for different programs to really build out our mental health system so that we can really meet the needs of people. Because we don't bill for services, we depend a lot on donations and grants, but also the NAMI Walks, which is our largest fundraiser. It's always the fourth Saturday in September. There's no fees. We want people to come and, you know, really kind of celebrate their mental health and talk about mental illness. We always have a great band, but I have to say that Minnesotans don't dance in the daylight. So it's kind of too bad because people just won't dance, but I'll stop there.
Thank you, Sue and Phil and Craig for couching us in your organizations. And I think as we continue the conversation, it's important to kind of be couched in the overall scope of need within our community. And so we have a few slides and information for us to have some general understanding of the issue. Knowing that 1 in 5 adults in America have a mental health challenge, with nearly 1 in 25 experiencing a serious mental illness. And so when you extrapolate that into our local neighborhood, into our states and our communities, that more than 1.1 million Minnesotans experience a mental health challenge, and also more than 225,000 are living with a serious mental illness. And so it is one where we know the issue doesn't know any socioeconomic bounds, any bounds. It is an issue that hits all of our neighbors and all of us across Minnesota and our communities. And on the next slide really shows a little bit of information that's even more local and more recent. So in 2020, there was a survey of Minnesota principals. It was conducted by the University of Minnesota and underwritten in part by the Minneapolis Foundation. It is one where, of all of the things that the principals were asked, they reported that mental health was really the most significant ongoing pandemic-related challenge that they experienced, not just for students, but for staff as well, and an area in which they needed the most resources. And that was in 2020. A more recent survey in 2022, just put out last fall, of 8th, 9th, and 11th graders showed continual increases in students who reported mental health challenges, it being up 6% from the last time the survey was done in 2019. The survey being done every 3 years. It showed too a disproportionate sort of impact on certain populations. So LGBTQ+ students were 3 times more likely to report seriously considering suicide and 4 times more likely to attempt suicide. and then teen girls suffering disproportionately in comparison to males. 45% of 11th graders identifying long-term mental health challenges, long-term being 6 months or more, compared to 20% of male students. So I will note too that these are statistics that can be triggering, especially if you have your own mental health story and your own mental health journey. I want to just acknowledge that the statistics aren't just statistics, but they're people's lives and people's journeys within the mental health space. And so I encourage you, if it's triggering in any way, to do what you need to do to take care of yourself. I just want to name and acknowledge that the information and some of the conversations can be hard to sit through based on your own personal experiences. So I think with this kind of couching of this, increase in the headlines that we've seen with the mental health crisis, I'm curious if Craig and Sue and Joe can really give us context onto why. Why are we seeing such an increase in mental health needs? Is it purely because of COVID, or are we doing a better job at identifying, but kind of help us understand the why behind this huge increase of needs?
Well, it certainly was increasing before COVID. We know that among our children and youth. But COVID really did a number on most of us, to be honest. I kind of view it as the loss. So there was ambiguous loss, especially among our young people, because they weren't with others. They didn't have their high school graduations. They didn't go off to college. They didn't get their first job. They didn't have prom. They didn't have all those things, which as adults, we're like, we don't even remember our high school graduation, right? But to those, 17 and 18-year-olds, it's absolutely really important to them. And then we had loss of routine. So whether it was not getting up and going to work or not going to school, that loss of routine is also hard on our mental health. I would say loss of connection. They weren't with other people. Not every family has 10 kids in it, right? I grew up in a family of 6. You had a party all day long, but when it's only 1 or 2 of you, that is really, really difficult, especially with parents often trying to work at the same time. We can't forget the loss of life. And so over 200,000 children in our country lost their primary caregiver. And so that also made it really difficult. And I think we also have to put in the loss of safety among our BIPOC youth because of George Floyd's murder, that also had a huge impact on our kids' mental health. The only other thing I would add is that we know that social media is just not always a good thing, and that children, in my day and age, if you were bullied at school, you went home and you closed the door and you were fine then until you had to go to school the next day. That is not true now. And so kids are often bullied all the time, and there is no respite and no time to really kind of heal and build back up your self-confidence as well. That's what I would add. I don't know, Joe?
Yeah, I really appreciate that information. So what I would offer is that what we're finding, and we talk about stigma, but I'm finding that in our youth, for many, there's much more of a comfort to talk about mental illness and addiction than probably when we were all growing up. And I think there's been a lot of work that's been done, but it's impressive when I really have conversations with my grandchildren, their friends, and it's like matter of fact when they talk about somebody, or themselves, struggling with depression or anxiety. The other thing tied to Sue's comments around, just people being isolated, and that we think about kids who actually were home and trying to do virtual education. What we have found is that when you get kids back in schools and in front of more professionals, we actually saw, let me just say this, with COVID, we actually saw a little bit of a dip of all people coming into hospitals and EDs. And we all stood up virtual care because we wanted to try to keep people healthy. But what happened is then kids started returning to schools and they had more professional eyes on them. And that's when we started seeing more and more access challenges into our programs and increased visits to the emergency departments and that. And so we see that through the seasons, but we certainly have seen that when kids got back into more in-person learning within the schools. And so those numbers are back up. They're definitely back up. I don't know, Craig, what would you offer from Washburn's perspective?
I think I would echo what both of you have shared, but I would also say we've seen an increase in trauma. So Sue alluded to some of the impacts that COVID had, but I think to go a bit deeper in terms of the impact for kids, the economic impact of COVID and the impact that had on families. So if during the course of COVID, your family experienced the economic distress, or you experienced food insecurity with that, or you experienced homeless during that, and that was your family, and you were a child in that environment. And during COVID, some of those things also peaked, and like homelessness is still like a variety of those things have continued to be issues and have been at sustaining levels, and that's impacted the level of trauma that kids are experiencing with that. And we're also seeing the prevalence of gun violence in schools. Like gun violence was always an issue in the broader society, but we're seeing more and more instances where unfortunately it's becoming more and more common in school environments, which if you think about, that's where kids spend a lot of their time. And it's not some removed thing that there may have been gun violence in the community. Now that's moving more into the actual school environment. And that's happened in our community and it's happened in other schools. And that also impacts children. And in terms of like traumatizing them and in terms of seeing the experience of that. And when people were together during COVID, there was an increase in domestic violence with people being in space where they couldn't go anywhere. And there are children in those environments that are in environments that are not physically safe environments or emotionally safe environments where they're observing that. So, I mean, just to do a little bit of a double click on some of what Sue talked about, some of those things really impacted kids in ways where if you think about everyone's combined together and there was an outlet for that period of time and there wasn't that outlet for the child to be out of that environment or the family members to be out of that, and that sort of was a pressure cooker. And we're seeing the impact of that for some of the things that Joe talked about as kids come back into these environments where there are professionals who can see kind of what the new sort of norm is and what's going on with that. And also where you're just more attuned to what's going on with people where a child may need more attention. And just to piggyback on something else that Joe said, there was a children's mental health crisis before COVID, but part of that crisis was, as Joe alluded to, a generational difference in terms of receptiveness and understanding of the value of mental health services, where the younger generations and children are far more comfortable talking about that, far more comfortable naming it, have more of a language and vocabulary around that, which increases demand for that. Not necessarily because the demand increased, but because more of the people who needed support are naming that and are aware of that and are seeking the care and showing up in surveys and naming that. But that intensified during COVID, where prior to COVID, about 20% probably of kids were experiencing depression, anxiety, or suicidal ideation. And it's even some of the data that's Amy just shared, that skyrocketed during the course of COVID, and it's not decreased. That has stayed at those levels, and I worry that it hasn't peaked. There have been high levels, and I worry that we haven't peaked with that.
Thank you. It really speaks to the fact that there's so many kind of overlaying things coming together that has created this truly exponential, unseen before sort of mental health crisis. So it's really helpful to hear the different kind of things that play into that. I think it's equally helpful to understand a little bit about the mental health system as we continue the conversation. And one is that recognizing that within this ecosystem of mental health, we know that mental health problems are treatable. There is certainly hope when folks get access to care and an effective treatment, they oftentimes get better or that level of severity decreases. And so recognizing that within the mental health system, treatment works and it's important. The challenging part, though, is that mental health system isn't currently responding to in a timely way to children and adults and families. And so certainly I know that the panelists will share how the wait list to see a clinician, to be matched with a clinician, is oftentimes months, which only allows that individual or that child to kind of sit uncared for and have that level of severity increase. And so there's certain things that are part of that mental health system that is so key. And I'm curious, I want to kick this over to Sue, because I think to share more about what that mental health system needs to look like, in part because, right, you've already said it earlier, and I've heard you say it before, the mental health system isn't built yet. It's not broken, it just hasn't really been built. And so if you can share more about what you mean by that and give us some of that context about what we need to be building into the system, would be really helpful.
Thanks, Amy. So if you think about, our mental health system, actually, 45 years ago, there were really no community services. And if you kind of look at the history, everyone wants to blame Ronald Reagan, but you really have to blame actually President Kennedy, because
Yep.
Kennedy is the one who said, we're going to close the institutions and we're going to build community mental health centers. What we blame Reagan for is the fact that he cut all the funding for community mental health centers, put it into a block grant, sent it out to the states with few strings attached. And so that's really what prevented our system from growing, along with the fact that, I'm sorry to say, but insurance does not still recognize mental health parity. We still do not cover mental health treatment like we do other healthcare issues. Just this morning, I was over in the Senate requiring all the health plans to cover psychiatric residential treatment facilities, which is an intensive form of care for children. And so we have children boarding in the ER who need this level of care, and private insurance won't pay for it. We have children boarding in the ER for mental health issues. If we had the same number who were boarding in the ER for cardiac issues, I can assure you the hospitals will build a new cardiac unit very quickly to make sure that we're taking care of people. So we just don't treat mental health the same way. It's not paid the same way either. And we often have to rely on grants to actually carry out the care, which also we don't really do that in the other parts of the healthcare sector. So I would say basically our insurance plans don't view our head as connected to the rest of our body, and that if you don't have money, it's really hard to build a system. I think related to that is we do have a workforce shortage, and we have for many years. Even President Eisenhower in his seminal report on how to build a mental health system said we have a shortage of child psychiatrists. So we've known for a long time, and we really haven't done anything about it. Overall, when we look at our workforce, about 49% of people who graduate from graduate school don't go on to get a license. And when we looked at why, a lot of it is that they've already have all these huge school loans, and now they have to find and pay for the 4,000 hours in supervision to become a licensed professional. And you can't always do that. And you can't always find someone who's from your culture or community to be your supervisor, which also makes it really difficult. So what we know generally is that a very small percentage of people actually access the care that they need. And right now, especially, we're just seeing super long wait lists. I had insurance often has very narrow networks for mental health. And I had one mom that I talked to recently, and it was going to be an 18-month wait for her teenager. Well, we can't wait that long. And when they do all the studies, they see that when you're seeking mental health care, you're far more likely to go out of network, which means higher co-payments, right, than other healthcare issues. So fundamentally, we need to start treating mental health as healthcare. I don't know, Joe or Craig.
Yes, I would.
You want to
Yeah,
add to that? There's a
Yeah.
lot. I just want to say there's not one thing that we can do.
yeah.
I always, I got asked this by a reporter the other day, like, what's the one thing we can do? And it's like, it's not one, it's many things that we have to do to really address this.
Yeah, I would. Thanks, Sue, for that history and that summary. As a service provider, we're overwhelmed every day by the demand, and we are fortunate to have Dr. Maribeth Larrazábal, who couldn't present today, but is a child adolescent psychiatrist, and really is very credible within the community. And so we have been able to attract child adolescent psychiatrists to Allina, which has been great. But I will tell you that every day we have children both in our emergency departments that are there much longer than we want them to be there, because we can't get them into the inpatient beds, because we have children who can't get out to the facilities that Sue just talked about because they really are limited and don't exist. So today I could tell you that we have 4 children between Abbott and United who have been in the hospital for almost a year waiting for disposition. They have complex needs, and we have counties that are actually will look not just within Minnesota, but they will send these children away from their families and support system to other states because we don't have the services here. This is where I want to just plug in, and I'm grateful for partnerships. This is where I'm grateful for the Washburn partnerships, because what we did at Allina is we actually have 3 clinical social workers that actually are assigned to Allina. And they not only take and help families in our emergency room, so they will take children and families home, and actually serve them in the home. And that's what we feel is the ideal state. Get kids with their families and provide that support in the home when we can do that. And then they're also helping children as they leave our inpatient units. What's really exciting is when our pediatric clinics and our primary care clinics are actually making referrals into Washburn from those settings. And we're seeing more and more of that. Let's not wait for the crisis to happen. Let's address proactively the need. And I can tell you, as a consumer of Washburn, that was a lifesaver for our family to have that in-home service there for my daughter when she needed that. And it was really a broad approach. I do want to put a plug in that Sue mentioned grants. One of the things that I am grateful is that Alina has actually made a commitment to two areas of philanthropy. One is cancer care and the other is mental health, and grateful for that. And so what we find is that if we can get the funds to actually open up and start programs and services, we can sustain them into the future. So we actually are going to be expanding beyond adult services up in the north to serving the lifespan. What we've learned is that we have so many children that have needs up in Anoka County and those communities, and quite frankly, we haven't served them well. And so part of our $25 million campaign that we are launching for an integrated center is really to actually expand those services beyond adults up in Anoka County to serve children, adolescents, or adults. And we have to pay attention to our seniors and the aging demographic. So really building out those senior services. So just really grateful to for those commitments. But we can't do this alone. And to Sue's point, it's multifaceted, right? It's not one thing. And I could give you stories of people who are denied services after a limited number of visits, and so quite frankly, we do the best we can to work on foundation funds to help continue to pay for care. We work on sliding fee scales, but it's just too costly for individuals to have to pay out of pocket, and they shouldn't have to pay out of pocket for their mental health care. I don't know, Craig, what would you add?
Yeah, I would just say we're equally grateful for our partnership with you and the impact that that has, Joe. So just want to echo that. I also want to build on something that Sue said and connect some of the dots in terms of some of the structural issues and how that ties to our day-to-day. We're also seeing our wait list expand. And our wait list probably have increased by like threefold during the course of COVID, and they've stayed at that level. It hasn't like gone down. They've stayed at this much higher level. But going back to the workforce piece, the workforce piece is tied to the rates. And one of the things Sue alluded to was the rates, but the rates don't cover the cost of delivering services. And I emphasize this because there are providers in the nonprofit space who are for-profit entities, and then there are those that are nonprofit entities. And for us, we rely very much on the average for our organization, only 80% of our expenses are covered by the rates. And there's at least 20% that needs to be covered through the generosity of donors and things like that. So we couldn't do what we do without philanthropic support. But part of the structural issue is that those rates should cover more than that. And that's 80% on average. There are programs where it could be as low as 30%, or it could be as high as 90%, but on the average, it's 80%. And those rates are not reviewed and updated on a regular basis. It's been about 10 years since the rates were reviewed and updated. And if you think about whatever inflation assumption you use, 2%, 3%, or during COVID, it was as high as 10% over a 10-year period. Clearly, we're at a disadvantage in terms of the majority of our expenses are tied up in cost for clinicians and labor cost. And with inflation over that time, it makes it very challenging to be financially sustainable in that environment. So that's one of the structural things, is that there is legislation right now to advocate for, I think it's a 35 or 45% increase in the rates while they conduct a study to permanently increase the rates, but that would have a huge impact in terms of our building our capacity. And that ties into the workforce piece, because for Washburn, your economic situation is not a barrier to you receiving care. So we'll take we have folks who are receiving medical assistance, or their health insurance is through medical assistance, or we have a sliding fee scale for people who may not be, the insurance may not cover everything with that. But in that environment, with the rates not covering that, and the majority of our revenue coming from that, that makes it very challenging to sort of recruit and retain people and pay them a competitive salary, where, like Sue talked about, in order to get licensed as a social worker, you've got to do these 2 unpaid internships, and it has to be unpaid. In other aspects of society, when you're in grad school or undergrad and you're doing an internship, there are no constraints on your getting paid for that if the organization can pay for that. For social work, they're like, nope, these have to be unpaid. You can't be paid during that time. So you're working to go to school, assuming debt for that. And while you're in school, you're working, but you can't get compensated for that. And then you come out of that in a field where many of the providers are constrained in terms of what they can pay you because of the rate structure. So that's a structural piece that I think directly ties into the overall capacity within the system, where our new organizations being started or even doing this work, because they can make the financials work, and our ability to recruit and and retain people who are in the field.
I
And
just
I'll
want to
just
offer, oh, go
add-
ahead, Sue.
Oh, I just was going to add that the health department did a study about, how much people get paid in these various professions, and a dental hygienist gets paid more than a marriage and family therapist. Now, I want someone to be nice to me when they clean my teeth, for sure, and it does take training. But the training that a marriage and family therapist has to take in terms of a master's degree,
Mhm.
4,000 hours of supervision, it's a lot more, and yet they're getting paid a lot less, tied to the rates as well.
It was when Sue shared that statistic of the those that don't complete their clinical training to become licensed was just really striking to me. We see this also with our licensed alcohol and drug counselors. There's so many of them that complete the coursework, but not the clinical training. And so there's a reality as a service delivery organization, we can pull people to provide the clinical supervision, but what we're doing is we're actually pulling them off from direct patient care. So it's that happens is that we have an individual that we dedicate 8 hours a week to just clinical supervision, but he's unable to see patients during that 8 hours a week. But it's that catch, and there's a cap where we say we can provide this much supervision for you, but we just need to balance the access into care with helping to train people. The other is to the point is to actually really provide the cultural support for our BIPOC clinicians to really complete that education, so that children and adults and individuals can really receive the care from people that look like them. It's extremely important. It's a huge barrier. Yeah.
And one of the bills that did pass 2 years ago actually funded BIPOC mental health professionals to become supervisors. So all of their classwork would be paid for. And we had over 200 people actually take advantage of that program, meaning about 400 more students can actually get their supervision from someone who looks like them. So I also want to tell people that there are a ton of problems, but we've also identified some solutions that actually work. And if we can continue to invest in them, we will continue to address this problem.
Oh, certainly, Craig, it makes me think of a little bit of the Pathways program too at Washburn Center. If you want to share a little bit about that program and helping with the workforce shortage and giving folks, individuals that look like them, that reflect their identities.
Yep, thanks, Amy. Yeah, as we've alluded to, there's a disconnect between the percentage of particularly Black, Indigenous, and people of color clinicians and the demographics of our client base. This is a big deal for Washburn because for at least the last 10 years, if not longer than that, over 50% of the kids and family we serve have identified as BIPOC, while only around 20% of our clinicians have identified as BIPOC. And as several other folks have alluded to, you get better outcomes when people stick with therapy. Poor people are more likely to stick with therapy if they share some type of cultural identity with their clinicians. So that's a big deal for us. So, and that's a structural issue for the field. It's not specific to Washburn being able to recruit BIPOC clinicians. It's an issue with the entire field. But one of the things we're doing to do our little piece for that is we have a program called the Pathways Fellowship. And the Pathways Fellowship is a tiered program geared towards people who are in school to become clinicians. So giving them mentorship support and coaching and education while they're in school so that they'll graduate from school. For people who are newly graduated and are pursuing licensure, getting them support to kind of find their way as a clinician and get support and help them with paying the fees and getting, courses and things to make sure that they get licensed. And then also a third track that's for licensed professionals, because there still are not a lot of BIPOC professionals in the field. So you still are sort of in this island by yourself and getting you support, but there's another community of BIPOC clinicians who you can tap into to support you in terms of navigating the care of your clients and also operating in those environments. So that 3-tiered program is focused on kind of getting people in, more BIPOC clinicians to graduate. Once they graduate, getting them licensed so they're not in that 50% kind of that Sue alluded to. And then once you're in the field, giving you support you need in a sense of community and support and coaching to allow you to stay in the field. And one of the areas we're talking about with expanding that is that's kind of limited to folks that are in Minnesota because of the nature. I won't go into the details of how you get licensed in the programs, but it's kind of geography based and very constrained to Minnesota. But if we want to diversify the field, we need to be able to go outside of that. So one of the ways we're looking at expanding the Pathways program is actually to do an internship during the summer where we'd be able to bring people in from other parts of the country that may have greater economic diversity at the undergraduate level, to have them think about Minnesota, because a lot of people in Florida or warmer places aren't thinking about when they're going to school, living, or even thinking about visiting the Twin Cities. So to get them out here in the summertime where they can see the Twin Cities in their best light, to get them thinking about children's mental health or mental health more broadly, because a lot of people aren't thinking about when they're in college, I could be a therapist supporting mental health of children, to get them into that environment. And for them to go back to their school and say, hey, you know, the Twin Cities is great, Minnesota's cool, and hey, there's this thing called children's mental health or mental health more broadly, and I might want to pursue a degree in that, change my major or go to grad school for that, and maybe I'll go to the Twin Cities when I do that. Because we feel like if we're going to diversify the field, that's a sector-wide issue, and we're going to have to go broader than just in Minnesota if we're really going to make progress on that.
It looks as though we lost Amy as our facilitator. So I just wanted to extend an additional question, and maybe Sue, you could share a little bit more about what is happening at the legislature around school-based mental health and sort of the partnership between Allina and Washburn through the school-based lens.
Sure. So one of the things that we found in terms of what works is to go to where people are. So what we found with children is that, of course, they're in school. And what we found is that parents have a lot of barriers to getting their child to therapy. And so before this program went into place in 2007 across the state, we found that very few kids were actually completing their treatment plans. And if you think about it, it's pretty hard for a parent to take off of work once a week for 22, 24 weeks, right, of therapy sessions. They just couldn't do it. And often the employers wouldn't recognize it as, frankly, real health treatment. So what we did instead is we're not asking the schools to provide this therapy. What we're doing is sending the grant money to community mental health programs and providers who then co-locate in the school. So they see the child in their own milieu. They can bill public and private insurance. So it's basically braided funding. The grant money pays for children who are uninsured or underinsured. So we saw a lot of suburban districts actually using this grant because families had $6,000 to $8,000, $10,000 deductible, so they couldn't afford it. But the other thing is there's also a firewall between the education records and the healthcare records, which was also really important to families. They didn't necessarily want teachers to know, their business, so to speak. And so having that firewall was also great. And the nice thing is that the providers can actually work with teachers to understand how to help a child in the future. So maybe you have a child in first grade who's doing school refusal due to real, high extreme anxiety. Well, that therapist can work with the teacher to understand some things that they can do. And so the next time a child comes in with school refusal, they also have a few, tricks in their bag to try to use to get that child to be more comfortable. We're in about a little over 60% of actual school buildings and about 85% of school districts. There is every year we come in and ask for more money for the program because we believe it should be actually in every school building. And the one thing that I'm sure Craig and Joe will be able to say this is that by about November or beginning of December, there's wait lists. So we know that this is a really important program. One year, quite a few years ago, the Senate actually was going to move to cut this program. And it is so well liked that teachers, parents, superintendents, principals came out of the woodwork to say you cannot cut this program. So it's wildly successful and loved.
Yeah, I can offer that. We know when the first parent-teacher conferences are held in schools. That's when our wait lists go way up when those conversations happen. I just want to offer a couple of things that around school-based care. And Allina has made a commitment to a web-based program that was in existence long before I joined Allina, but called Change to Chill. And so we support this in a number of different schools across the state, and it's a web-based site that was originally really created by kids for kids. It's recently been put into Spanish. It's oftentimes there are champions that are at schools that help users. I have a spouse who's an educator, and she's in a kindergarten classroom, and she finds very helpful tools to use in the classroom. You can teach mindfulness approaches to kindergartners and relaxation just to deal with anxiety and stress within that setting. The second thing is we received a grant to actually work with the Anoka Hennepin School District when they surveyed the teachers about some of the tools that would be helpful to them. Is we created a library of podcasts for teachers that they could listen to while they're on the treadmill, while they're out for a walk, while they're driving back and forth, just as teachers to give them tools to how to identify needs in kids and to also address needs as kind of an early intervention type of approach. And this is actually within middle and high school. So we have about 50 different podcasts that we produced that they're using within the Hennepin Anoka School District to help them. Oh,
Yeah,
Craig.
and I would just add, one of the additional benefits of school-based is that the expansion of telehealth for mental health is phenomenal. Like overall, the fact that financially there were constraints and limits on what we could do, and that during COVID, a lot of those were lifted. So that made it like more accessible, and to places where there aren't clinicians, where if you're in an area where there aren't any mental health professionals for you to get care. So telehealth and telemedicine overall for mental health, I think, is phenomenal. I will say that one of the benefits of the school-based model is telemedicine and virtual does not work as well for little kids.
Great.
It works as well for adults and teenagers, but for little kids, for the nature of therapy for younger children, a lot of it's play therapy, a lot of it's interactive, some of it's tactile, and it doesn't translate as well to the virtual environment. So that's better than nothing. I want to say that that's better than nothing, but you definitely see a difference in terms of the engagement with that. So that school-based model is a way where people are still sometimes a little skittish about in person and everything like that, having the clinician based in the school. The child's already going to be at the school. The parent may already be going to the school on a regular basis for other reasons. It makes it easier to connect with the parent. It makes it easier to connect with the kid. As Sue talked about, to get into the whole system, we're in the district, we're in the school, to make sure that we're aligned with all the other resources that a child may need that's not from a Washburn service. So there are other resources that a child may need that can support their support. It's much easier where you're in that ecosystem already and you already know all the players in that ecosystem. And there's the stigma. If you're getting pulled out to go somewhere, well, where are you going? Well, I'm getting ready to go to this, and you have to explain that. If you're in a school environment, kids are in school all the time. They get called out of the classroom for a variety of stuff. It minimizes some of that stigma of you getting away and some of the travel and the parent having to go that talked about. So the school-based model is a hugely impactful model. And it's actually an area where during the course of COVID, we saw significant growth driven by, as school districts were understanding the magnitude of the mental health issues their students were facing. They were saying, we need these resources in our school. We need it with someone who has sort of this center of expertise that's not just someone in the school sort of on their own, that can tap into sort of this center of expertise, the training, the knowledge, and everything that comes with having a clinician who's tied to a broader mental health organization with that. So that's an area where we've seen significant growth, and we see that's a great way of meeting the need that continues to rise, because there's a lot of other barriers for a lot of the other things, and that school-based model and anchoring that is so impactful in terms of the therapeutic outcomes.
I could add one thing, because you all provide direct services and I've been talking more about policy stuff. There is a class that actually NAMI provides called Ending the Silence. It's a national program and it's to high school students. And we actually brought it to 8,000 high school students in our last fiscal year. And we do it all over the state of Minnesota, We also developed a middle school program as well, because it's a little different than Ending the Silence is really high school students. You got to do something a little different for middle school. It has to be more interactive. And so we have that program as well to really help kids identify those symptoms in themselves or others, and to know what to do, right, about a friend or themselves in terms of suicide prevention. So I just wanted to throw that in there.
Yeah, thank you, Sue, because I think those real tangible resources are really important for us to understand what exists out there, along with the overarching issue. I'm curious, Joe, I want to go back a little bit, since we covered school-based mental health, to go back a little bit about within the hospital system. And, you know, you're saying, we read the headlines, we see the news stories about the emergency rooms being flooded and not having space for folks to be moved into. Just tell us a little bit more about that kind of scenario, and what happens to the 4 kiddos that you mentioned that are, you know, in the system, if you will, for a year without having anywhere to go. Tell us a little bit more about that.
Sure. And so certainly, as I had mentioned earlier, we see some of these seasonal trends with increases in volume and that. And so we have 12 emergency departments across the state of Minnesota. And so, you know, what many people do is they think about, you know, when they're in a crisis, many of us think about going to the emergency department as a place to get care, because they can't access services. They can't wait for the 3 months for a waiting list to get in to see somebody. And so that is out of desperation, that's where a lot of families will bring their children. Emergency rooms are set up really as acute sites to address really significant needs. And those are environments that are high activity, high stimulation for people, and not therapeutic in the least. And I think we've all done our best to create mental health areas and that. And I would say that we have a lot of work to do. I would not call those environments in the least healing environments at all. They're more secured environments that children go into, along with other age groups as well. So a lot of fast paced, a lot of fast moving, and an ED, when you think about somebody comes in for a heart attack or they have had a stroke, it's quick assessment and really move and get them to the right level of care. And so to Sue's point, if we would never expect somebody with a heart attack to spend weeks in an emergency department, we surround them and get them up to a cardiac unit. Now, there's patient flows and there are demands as well, but it's just that its demand far exceeds our capacity to be able to admit timely, and it's a domino effect. The domino effect is those children that are ready to go but have no place to go. It might be a community service that's not available for or doesn't serve a certain part of the community. I mean, we serve children, sadly, from across the state. It's not just people that live in Minneapolis and St. Paul that go into our inpatient units. And there aren't enough of the inpatient beds for those that do need them, even with our best efforts to send to partial, to send to day treatment, to send to Washburn, and the demand is so great. So what we end up doing is we bring together for children who are in our emergency department and do not require an admission. We actually bring together families. We bring together community-based social workers. We bring together counties, and we huddle. We call it a huddle. And we come together for 30 minutes a day, and we identify what are the barriers for this child. And it's all done virtually. And we bring in parents to this, guardians, foster parents, and that to really hear the story of what the needs are. And some of these stories are heartbreaking. A child just is in such distress that they become aggressive at home, and they're getting older and they're getting bigger, and families are don't have the ability to manage within their home environment, so they seek help in an emergency department, and it doesn't feel good because it's not the best place to receive care. So we do planning in 24-hour increments, and we work with our community partners to understand that in an emergency room setting, we think about care in hours, not days. And really, we say, what can we accomplish for this person to be able to move them to the right setting? And so what can we accomplish within 24 hours? So to Sue's point around it's multifactorial, I mean, it's amazing how just determining what funding stream can we get to support this individual? Is it mental health funding? Is it DD funding, developmental disabled funding? What funding is it? And so I've literally picked up the phone and called up county social workers to ask them to move an application from their computer to another computer just to get an application processed for funding. And I'm sure they're overwhelmed, but the squeaky wheel, right, gets the grease to be able to get that. And so what we do is we ask leaders to join in these meetings. We want everybody to experience the pressure. And so we've recently engaged with the Department of Human Services in these conversations to say, you need to understand the problem. And you need to feel some of the pain with these families are experiencing. And so you might be irritated that Allina Health is calling you to a meeting every day for 30 minutes, but you're not that child living in an emergency department, And I mean, I will tell you that our staff are amazing. I mean, they're identifying what these kids enjoy, and so they're bringing in. They don't want to eat hospital food, so they're bringing in McDonald's or Subway, and taking them for walks and those kinds of things. And we've established primary nursing in an emergency room setting for children who have been there a long time, because the nurses are wanting to do that because they've developed a rapport. So we're making the best out of a really, difficult situation. And I will just tell you the story that breaks my heart is when a little boy, Tyler, was in our Mercy emergency department for 3 months. 3 months. And his mother sent me a thank you note thanking us for the care we provided to his son for 3 months in a windowless emergency department. It brought me to tears to have a mother express gratitude. The staff were caring, but his needs were so complex that it took us that long to really find a place for him to be able to receive safe care.
Can we ask questions?
Yes, indeed, Parker. Thank you. You helped us transition, Parker. Thank you, Joe, for that
Sure.
story. I think those stories are important. Parker,
They do wonderful work. I understand you do wonderful work. But one thing that we're very don't know about is this business about rates. I heard recently that the legislature actually sets rates for people who take care of old people and caregivers. And so you talked about rates, but where do those rates come from and who makes them? And what can you do about increasing them? Or what can we do? Yeah.
So the
Sue, do you want-
legislature basically sets rates for Medicaid, and the Department of Human Services implements them. And there's sometimes, a little wiggle room in there. But for and this is only for Medicaid, Medicare is a different rate setting structure that's on the federal level. But anyone on Medicaid, their rates and the providers' rates are set by the legislature and the department. And so you have to call your legislator, basically.
You have people going to the legislature and saying this isn't enough.
Oh, I am there a lot. Yes.
Who lives there?
Yes. I will say, so there's a thing called the Mental Health Legislative Network, and it's a coalition of over 40 organizations focused on mental health. And this year, because we knew there would be about 50% of the legislature would be new, we all decided not to go in with our own bills, but actually go in together. So there's actually 18 bills being pushed this session by the network. That focus, that really covers every area of the mental health system that you can think of: housing, employment, education, rates, a variety of things.
If I can add to that, Sue, that's on the Medicaid side, but there also are the commercial rates.
Yes.
And I would just say one of the other challenges, and a significant proportion of the folks we serve are getting the Medicaid rate, so that is a big deal for Washburn. But there also is an issue with the commercial rates, and Sue alluded to this parity piece, where people go to medical school, and there's a lot of debt to go to medical school, and you get paid a lot of money for that, and the rates reflect that. So rates for, services that require someone who went to medical school were much higher than the rates for someone who's a marriage and family therapist or a clinical social worker. But that's also because part of the cost structure is you're paying them more, and there's an acknowledgement of that. Where Sue alluded to sort of this parity of rates, that's a big deal. Or even on the commercial side, there's been a decision because of the stigma around mental health, where the mental health was not viewed on the same way as physical health. So you go to medical school primarily to take care of the body, and we value that more than we value the mental piece. So the rates are going to be lower. And there's not like a reason. I mean, there's a reason for that in terms of how we rounded up where we're at. But if you look at the body is the body, and mental health and physical health are the same, and we should get the same level of care for that. If you start with that, the rates wouldn't be there where they are. So there is even a parity issue on the commercial side in terms of how society and the healthcare industry views mental health, and basically denigrates that, whether it's relative to physical health, and decides it doesn't want to pay and invest as much in that on the commercial rate side as well, that I want to speak to too.
Amy, we have another question that I'm going to share from somebody. So how does Minnesota compare to other states in terms of available mental health services? And maybe share a bit about what is Minnesota doing well, and what are the areas that we could be doing better?
So we're typically in the top 10, which is sad. So you definitely don't want to live in Florida or Texas in terms of their mental health systems, pretty much anywhere in the South. So we're good among a bad system, basically. I think some of the things that we do well are things like the school linked grants. We have mobile crisis services covering all 87 counties in Minnesota, which is also really important. So people can get a mental health response to a mental health crisis and not a police response to a mental health crisis. They're not funded how we do other first responders, but it's still a really good start. I think we do focus a lot on community services and not state-run institutions, which I think is also really important. We have residential facilities for adults that are 16-bed facilities, so Medicaid can pay for them. We have facilities for kids. We have assertive community treatment teams. We have those they're kind of like wraparound hospital care, basically, but in the community. We have it for youth as well. So we have a lot of good things. What we haven't made sure of is that they're accessible to everyone in Minnesota and throughout the state of Minnesota. And so that's what makes it difficult, to be honest. And that's why we're not meeting the needs.
I would piggyback on Sue's comments. The other thing that we do well is we collaborate. Well, I think years ago we decided, there's not competition in mental health and addiction in that space, and that the only way that we're going to be able to do this if we do this together. And so, I think about, the partnership through the Mental Health Legislative Network. We always look at kind of, Parker, to your questions, we always kind of use that as our guide at Allina Health for where are we going to focus and help support and prioritize through our own public policy division to support those bills that are going through. And so instead of us going out on our own, really doing that in partnership with that network. I mentioned the Washburn partnership, but we have 16 other community partners that we could not do this work. We have a comparable adult partnership that helps keep individuals living with mental illness and addiction healthy and in the community. And they do a very similar approach to helping adults leave our emergency department, transition from inpatient stay, taking referrals out. The other is, I think where people are starting to really understand that there's more to than just an inpatient admission, the intermediate levels of care. If you can have somebody sleep in their bed, if they have a bed and they can sleep at home, and then come in for day hospital programming, that's really the best. When we can offer that, it gives them more dignity and approach. And I think the other thing is, we're one healthcare system, but other healthcare systems have made commitments to mental health as well. And so we talk about that together. What can we do alone? What can we do together to really strengthen, service and care?
Focusing on that community is just one other thing I wanted to mention, is that unfortunately, often people bring up, well, Minnesota has the lowest number of beds per person, per population than any other state. And the interesting thing is if you actually look at the report, the only beds they counted were state operated beds. And in Minnesota, we don't expect our state to deliver care, like we don't expect them to do cardiac care or anything else. But if you were to add in all of our community hospital beds, we would be up in the top 10. So I think it's also important to know that in Minnesota, we don't look to to state institutions that are providing our mental health care. We look to our community.
That's great. Thank you for sharing. Here's another one. You talked a little bit about workforce shortage earlier. The question is, in what ways do your organizations support your staff to promote self-care and retention, knowing that burnout is real and compassion fatigue are real?
Yeah, I would just like to offer that we have a couple of tracks of employee well-being that we are engaging. And so we have seen and know that physicians, not psychiatrists alone, but physicians have a very high rate of depression, anxiety, and a very high rate of suicide. And so we actually have launched a provider well-being strategy within Allina, which will culminate in a center that that again our philanthropic partners are helping us to fund to build. We have the team to support it. We just need the space. At the same time, we're looking at all of our workforce through an employee well-being strategy, because you're right. I mean, there is fatigue. You know, we think about what all of our healthcare providers went through COVID. And as we think about post-COVID and the high demand, not just for mental health. I mean, I go to meetings every day that we used to always focus on the mental health patients waiting. Now we talk about medical patients waiting to get into beds because we don't have the staff to staff all of our beds. In order to provide the care. That's draining. That's exhausting for all of our staff to provide that. So we're looking at, it's everything from peer support for individuals, mental health and addiction care, as well as two of our tactics within the strategy. We got very comfortable with virtual care, virtual meetings, I should say. Look at us coming together in this way. We're very comfortable with this, right? And I think that we lost connection. So we've really started to engage more as leaders within our organization in those connections and making sure we're out there with our staff as they're providing care, listening to them. And I think it's a multi-pronged approach, but those are some of the things that we're doing within Allina to really reinvest in those relationships with our staff.
Yeah, I would say at Washburn, we're looking at two buckets of activities. We're looking at individual wellness and we're looking at organizational wellness. And how does the organizational wellness support the individual and how does the individual support the organization? So on the individual level, making sure that our medical plans provide coverage for therapists to get a therapist, because that's huge. And not all the medical plans have broad networks. Not all of them make it cost effective for therapists to get therapy. So that's a systemic piece that we look at with that. We also look at generous time off and sick time programs so that people can take time away to recharge that's needed with the demand that's there. We also have a significant focus on training, making sure that our clinicians are trained in evidence-based practices, because part of what we see with wellness is, as we're dealing with cases that are more severe and more complex, that we're coming up with stuff that people haven't dealt with before, and increasing their toolkit as clinicians with other evidence-based practices and training them makes them feel more competent and gives them a broader range of tools they can tap into that makes them feel better about the work they're doing and have a better impact on that. We're also looking at connection, as Joe alluded to. That's been huge. A big part of our kind of wellness and self-care is connection. When you're isolated and you're dealing with people who are traumatized and supporting them and giving your heart and soul to them, you need your cup filled. And part of that is being in space with other people who get the work, who understand that, who can help you navigate that. And with everything being virtual, that sort of had a negative impact on that. So we're being intentional around bringing our entire organization back together, because we work in all these different programs that are geographically dispersed, and letting people come together and kind of bask in the awesomeness and the love that is the Washburn energy and see that. So we actually are doing community engagement days that we're doing intentionally about that. And one of those was Mental Health Day on the Hill, where we actually had our entire organization showed up for that. And that was an opportunity for us to come together as an organization to advocate for some of the legislation that we've talked about here, to be in space with each other, to meet with your legislator, to be with other members of the community who care about mental health, who are passionate about that, and for us to be in space together. And we're going to be doing another community engagement day like that. We're going to be out in the community volunteering with that. And we're also being intentional around bringing people together for all staff meetings and in doing things that we can only do when we're in space together, to take advantage of us building the connection with each other and having fun and kind of to enjoy each other's presence again with that. And finally, we're doing wellness plans where each team is sort of developing an organizational wellness plan for their particular team to address the particular needs of their program. Because we have people who are operating in schools, people who are in people's homes, people who are at one of our 3 sites. So the teams have very different needs in terms of what the individual wellness needs of the team members are and kind of what the collective needs of the team are, and having plans that are sort of geared around that.
Thank
And
you,
we, of
Craig.
course,
I
have a
think it's
much-
really,
Oh, I was just going to
Sorry,
share
Sue.
what NAMI does. So we're a much smaller staff, but we do actually in our space have a quiet room where people can go if they've had a bad call, or if they taught too many suicide prevention classes in a row. And we have weighted blankets and things like that in there. We also offer SAD lights to any staff who needs them during our winter months. We've paid for the Calm app for all the staff so they can access meditation and nighttime storytelling, for adults to help you go to sleep. We also do a lot of accommodations in the workplace and making sure people know about our EAP. And as we hired new staff, during the pandemic, we actually appointed a work buddy, so they'd have somebody who would reach out to them and keep connecting. And then lastly, really looking at our health plan. And so we have made every effort to have a $500 deductible. So there's not a huge barrier in terms of people accessing care.
thank you. I think these really important questions, and I apologize that we won't get to every single question that's been posed, in part because I want to end us with one really important question, which is, how can we help, right? You have, Joe and Sue and Craig have steeped us in the challenges facing the mental health system, challenges facing our neighbors. And part of this Learning Collaborative series is really trying to understand, get closer to the issue, and then how can we get closer to those community-driven solutions? So I invite each of you to share, how can we as individuals be helping further the issue and build that mental health system that we need? Sue, do you want to start us out?
So I guess a couple things. One is to share your story. So if mental illness has impacted your family, it really is important that we share those stories to really change the attitudes around it. The second thing is to call your legislators, your state representative and senator, because I've seen these 40 some years, what a difference it makes when people actually call their legislators, because they don't call a lot about mental health. And if you're not sure what bills are going through the legislature, NAMI does a legislative update every Sunday afternoon or evening, depending on how long it is, that tells you more than you ever wanted to know about what's going through and when your calls are needed. And lastly, I would say just, support a local mental health organization. Any of us, there's lots of people in the state of Minnesota doing this work, and everyone kind of needs your support.
I would offer, I support everything that Sue said. I think that in addition to telling your story, acknowledge your loved one, your neighbor, your coworker who lives with mental illness. We're good at sending flowers for medical needs and those types of things. Send a card, make that hot dish, deliver that to somebody's home that's struggling. That could be the boost that they need, and they'll probably not expect it as well. Really, again, I was going to say the same, to call your legislator to really advocate for these. That's where, as Craig was talking about how rates are set and going and asking for those to be changed. This is an important time for all of us, and it will be every year. And align, work together and collaborate, and then make connections. And so again, it goes back to those partnerships that we need each other in order to really do that work and make those introductions.
Yeah, I would piggyback on the advocacy. The state has much more resources than an individual organization does, and there are structural things, as Sue has talked about. So that NAMI legislative update that NAMI does is amazing. So get on the mailing list for that, because that
Yep.
really is a very comprehensive view of where the legislation is at, what it's about, so you can know who you need to engage with. So echo that. I would say consider doing a mental health first aid course. People go to get certified on CPR and on first aid. Well, there's mental health first aid courses that the National Council on Wellbeing kind of has people who instruct on that. And I think that's another way in terms of deepening your understanding, your ability. If someone said, well, what can you do when someone's in crisis, or what do you do? One of the things is getting trained in mental health first aid, so you can see this is a mental health things. These are things that are useful. These are things that are not useful with that. So that's something I think that you can do that also builds awareness around that. And Sue alluded to this, but the rates don't cover the cost. So that donating or financially supporting or supporting, the philanthropy within an organization is really, really important. Because unfortunately, during COVID, when demand is peaked, we saw quite a few mental health organizations that went under during that time, that were nonprofits, that were not able to make the financials work during that time. And that philanthropic support is critical to the survival, I know, of Washburn and of many other organizations. So that can have a huge impact as we deal with all these structural pieces. That piece has a huge immediate impact on a day-to-day basis.
Thank you. I think it's really important for us to walk away with tangible things that we can be doing, again, because our Learning Collaborative series is meant to offer insights, help folks get more proximate to the issue, and then more proximate to those community-driven solutions. So there's one final slide here, which kind of answers one of the questions, which was sharing contact information and sharing resources. One, we certainly want you to walk away with understanding what to do if your family member or a friend is in a mental health crisis. And so that 988 crisis lifeline is one to connect with, or to see kind of real-time availability, check out fasttrackermn.org. And the websites for the individuals are listed here, along with contact information. We will send all of this slide deck out as well after after this event. But certainly, again, want to thank you and invite you to continue the conversation, to get proximate to the issue, in hopes that this inspired you to act differently. You've certainly heard a lot of those solutions and opportunities with signing up for NAMI's legislative updates, which we'll be sure to include that link for easy sign up in our event recap as well. And engaging also too with some content that exists. Sue took part in a podcast with Shonda, who leads our community impact team, earlier this year, or last year. So we will send that link as well. But continue to be engaged in dialogue and in conversation with the resources that we send and follow up, but also with your philanthropic advisor. Help us know if this is something that you want to continue to get proximate on, and we can help kind of direct your philanthropic goals and giving in an opportunity to really help us build that mental health system that we are looking for and needing to support the issue. So I want to thank all of you for joining us.